Hello, this is Dr. David Green, CEO of the Texas Pain Network. Today's topic is, what are the best treatments for spinal stenosis? Well, first of all, what is it? It involves a narrowing of the spinal canal and pinching of nerve roots. Usually it's due to bony and soft tissue overgrowth from spinal arthritis, and usually it occurs in patients over the age of 50 and is often seen at several levels, and it's typically not symmetric. Here's an example, a cartoon picture. So here's a normal level. You have disc here, spinal canal that looks wide open. You have the spinal cord here, okay, and there's a lot of area around it, all right? That's normal. Here you start to get spinal stenosis. You get arthritis in these joints, this facet joints with bony and soft tissue overgrowth, and then bulging disc coming back out, and it starts to get pinched in the spinal canal. So it turns from a nice ellipse to a little bit more of a triangle, and that's called spinal stenosis. So what are the symptoms? Well, first of all, it may have no symptoms. Okay, you can have very obvious spinal stenosis on an MRI with no symptoms at all. But if it is symptomatic, typically it's an aching pain in the buttock and leg on the affected side. May have symptoms of sciatica, may not. It may just be in the buttock and down into the thigh a little bit. In unusual cases, you can get some leg weakness. It also may be mistaken for a hip joint problem because it may come around to the hip. Typically it's position related. Leaning forward often makes it feel better as it frees up the nerve roots, opens up the canal. So someone might say, oh, I feel a lot better when I'm leaning forward at the supermarket, on a shopping cart. It just, the symptoms aren't so bad. Or they may feel better when they're walking upstairs because you're leaning forward when you're walking upstairs. Now, there's a differentiation that needs to be made between neurogenic claudication versus vascular claudication. Vascular claudication is when there's a vascular issue. You get peripheral vascular disease, and that's where you start getting leg pain. And, out of a textbook, it might be the neurogenic claudication starts from the hip area and goes down, whereas vascular claudication starts in the calves and goes upward. Neurogenic claudication kind of comes and goes, but vascular claudication also comes and goes, but it's usually at a set time point. Like a patient will say, every time I walk about two street blocks, I start getting these symptoms in my calves, and it starts to go up the leg. So it's usually more time sensitive as opposed to neurogenic claudication, which is position sensitive. In reality, as I mentioned, most people have spinal stenosis have no symptoms at all. They don't even know they have it. So for symptomatic spinal stenosis, treatment options first and foremost should be over-the-counter nonsteroidals and Tylenol. Okay. Then you could have Neurontin and Lyrica. There are studies that show that these can work very well. We don't actually know how they work. They're called neurogenic stabilizing medications. We just know that they do work very helpfully. Physical therapy can be helpful. Spinal decompression therapy is intermittent spinal traction that can work well. And then epidural steroid injections have been the gold standard for decades for spinal stenosis. Here's an example. This is a caudal epidural injection where the needle is placed through this area here called the sacral hiatus, and then a decent dose of numbing medicine and steroid is placed, and through gravity the medication goes up to get multiple areas. So if you have multiple nerve roots being pinched, it can help provide pain relief for all of them. Whether or not to have surgery for spinal stenosis is truly a quality of life decision. Nobody ever died from spinal stenosis. It really is one of these things where if you've tried all these non-operative methods and they just didn't work, then that's when the decision should be made. A lumbar laminectomy is the treatment of choice. Now, if you decide to have surgery, first and foremost, you need to have a lumbar laminectomy. It may be that you have a central decompression. That way both sides are decompressed, or you just have it on one side. Usually it's about 30 to 60 minute procedure. You really don't need a fusion. However, if there's instability or whatnot, then it may be that you end up having to get these levels fused. That adds a whole level of complexity to the procedure. If you just do a laminectomy, it's a low-risk procedure. 50% do end up with some back stiffness postoperatively, and there is a chance of post-laminectomy syndrome. What that means is that if you free up a nerve root, it may do really, really well for a while, but there's a small chance that it could develop some scar tissue around it and then start to have consistent pain. That's post-laminectomy syndrome. The bottom line is that surgery can be avoided over 90% of the time. Epidural injections can be repeated every few months. Surgery is a quality of life decision, last resort, and if you do a spinal fusion with it, if you have one, it adds a whole level of complexity to the procedure. The top non-operative pain management in Texas is through the affiliated clinics with the Texas Pain Network. There's over 50 insurances accepted and over 25 treatment options with the board-certified award-winning doctors. Visit us online today at texaspainnetwork.net and then call us for more information and scheduling at 877-877-8556. I'm Dr. David Green with the Texas Pain Network. Your pain stops here.